Hello, everybody, and welcome to one of our series of the UCARE LevelUp Webinar. I am Dr. Iman Nasr, consultant immunologist and allergist at the Royal Hospital in Oman, and it is my great pleasure to start and kick off this meeting regarding the guideline recommendations and updates on chronic spontaneous urticaria, definitions, diagnosis, different steps of treatments, what are the updates, and how to use it in regard to chronic inducible urticaria. Today, we have our distinguished speakers who are actually experts from the authors of the guidelines themselves. We have Torsten Zuberbier, we have Professor Margarida Gonçalo, and we have Dr. Désirée Larenas-Linneman. So, to kick off, I would like to introduce the first speaker, Margarida Gonçalo. She is the head of Department of Dermatology, Coimbra University Hospital, an invited professor with aggregation Dermatology, Faculty of Medicine, University of Coimbra, who will be speaking about the diagnosis of chronic urticaria, how to evaluate disease severity. Then we have Professor Torsten Zuberbier, who unfortunately could not make it live today, but has recorded his session as he has passion for chronic urticaria. He is the director of the Institute of Allergology at the Charité University in Berlin, Germany. He's the president of the EU network, Guideline, that's the Global Asthma and Allergy European Network, and head of the European Center for Allergy Research Foundation. He will speak about the treatment algorithm and treatment adjustment. What do the recent guidelines say? And finally, we have our lovely Dr. Désirée Larenas-Linneman. She is the head of the UCARE Center in Mexico, a center of excellence in asthma and allergy, Hospital Médica Sur in Mexico City. And she will be talking about treatment options for chronic spontaneous urticaria and chronic inducible urticaria. What's the best for each? A brief overview of the guidelines. We will leave the questions and answers till the end. And very briefly, I'd like to tell you a bit of ourselves. What is UCARE? So UCARE is a center that treats urticaria and stands for Urticaria Center of Reference and Excellence. It's part of the Guideline network with over 120 member centers in 39 countries. What is the aim of UCARE centers? Simply to improve the management of urticaria. It's a common debilitating and often hard to treat condition that can be challenging for both patients and treating physicians, especially when chronic. And this is why we are all here today. More and more centers are joining this network, and 2021-2022 was dedicated as a special focus for physicians' education and information through the program UCARE LevelUp, or ULU program, and also information and education for patients, which we call the UCARE for You, or U4U program. What is the UCARE LevelUp? It is a physician information and education platform and program. We aim to create an interactive, visual, and comprehensive environment where healthcare professionals worldwide can learn, network, and share best clinical practices in chronic urticaria. So please participate in and use the UCARE LevelUp activities. It is free of charge. What are the programs? We have 10 online formats and activities, webinars, quizzes, physician education and resources website, newsletters, podcasts, fire chats, videos, online journal clubs, virtual grand rounds, and poster sessions. So stay connected, bring your phones up and click on the QR code here. You'll see all the educational video contents, and also subscribe to the newsletters and our other channels. Find more about the UCARE for You patient information platform through the QR code UCARE for You and the Urticaria Day, which we celebrate every year on the 1st of October. Stay connected. We are available on Twitter, LevelUp, LinkedIn, TikTok, YouTube, websites and Instagram. And if you're interested in becoming part of one or more Level Up task forces, this is the QR code where you can simply scan it, register, and we will be very glad to have you. So let's start the webinar, Guideline Recommendations and Updates on Chronic Spontaneous Urticaria, Definitions, Diagnosis, Different Steps of Treatments, what are the updates, and how to use it in regard to chronic urticaria. Don't forget to leave your comments, questions in the Q box on the Zoom window. So I'll introduce my first speaker, Dr. Margarida Gonçalo. Please, the stage is yours. She will be speaking about diagnosis of chronic urticaria, how to evaluate disease severity, and we have 10 minutes for her talk.
So this is my turn to speak, and I want to thank for the invitation to present this, collaborate in this UCARE LevelUp. So these are my conflicts. So let's begin with definition of urticaria, and especially chronic urticaria, a condition characterized by the appearance of wheals or angioedema or both for more than 6 weeks. And as you have seen already, these new guidelines, there is definition of wheals or these sharply circumscribed lesions, sometimes with edema in the center and erythema around, that are itchy and usually resolve in less than 24 hours, whereas angioedema is defined by the sudden onset of the skin-colored swellings on the skin or mucous membrane that do not itch so much and can have burning or pain and take a little longer to resolve. This situation is quite frequent and can involve every age, affecting mostly adult women, whereas the difference of sexes is not so frequent in childhood and after menopause. And you know that we have chronic urticaria where lesions are mostly spontaneous, and in certain cases you can have more inducible lesions, or you can have both. But let's focus on the theme of our presentation. Is this urticaria, or particularly I will talk mostly of chronic spontaneous urticaria, and how severe is it? And according to the guidelines, when you think about this disease or these lesions, first of all, you have to confirm the diagnosis, and clinical history and physical examination are the mainstay of this confirmation. But you also have, in the workup of these patients, you have to look for underlying causes and identify conditions that can modify disease activity, look for comorbidities, and evaluate the impact of disease. I won't speak much about this, but this can be done also mostly by clinical history and physical examination. And apart from confirming the diagnosis, you can also try to assess predictors of severity and treatment response. Again, I reinforce the importance of the clinical history and physical examination, even though sometimes when the patient comes to the consultation, he can have no lesions, but most of the time they bring us photos that we can see. And in all cases, we could do a very simple laboratory workup with a complete blood count and inflammatory markers like C-reactive protein or erythrocyte sedimentation rate. And eventually, if you want to know a little bit more, you can also do total IgE and anti-TPO antibodies. But you have to be aware of urticaria mimickers, and you have to think about differential diagnosis. And if you have mostly urticarial lesions, or if you have urticarial lesions, you have to think about urticarial vasculitis, autoinflammatory syndromes, hereditary ones, mostly when you're dealing with children, or acquired ones when you're dealing mostly with adults, and think about urticarial dermatitis that I'll speak a little bit further. And if you only have angioedema, it's very important that you think about bradykinin-mediated angioedema. both hereditary, acquired, or drug-induced, because the prognosis and the treatment are completely different from chronic spontaneous urticaria. So let's think about urticarial lesions. One of the situations you have to think about is urticarial vasculitis, where you have urticarial lesions that may leave this purple lesions when they go away, this transient purpura, or even purpura, as you can see in this situation. And in urticarial vasculitis, you can have hypocomplementemic forms of urticarial vasculitis, where C3 and C4 are low. Sometimes C1q is also low because you may have antibodies directed against this fraction of the complement. And you may have this hypocomplementemic vasculitis syndrome with glomerulonephritis, involvement of the eye and systemic organs that can be quite severe, or you can have urticarial vasculitis associated with lupus or Sjögren's disease. In these cases, you will have in the skin biopsy a leukocytoclastic vasculitis. For me, the most difficult to distinguish is normal complementemic urticarial vasculitis. And actually, we see many cases of patients that have a typical chronic spontaneous urticaria with typical wheals that sometimes during some severe accesses, they last longer. They may also leave this transient bruising, as you can see in the images on the left. These are patients usually have a CSU with longer duration. They will have a slightly higher CRP, and they are tenderly poor response to treatment. And on histopathology, it's not always very easy to distinguish this from really urticarial vasculitis. You don't have signs of vasculitis. You may have more eosinophils and less mast cells, as we have shown in this paper we published a few years ago, but it's sometimes difficult to distinguish this from real normal complementemic urticarial vasculitis. And still in urticarial lesions, in autoinflammatory syndromes, remember Schnitzler syndrome, where you have urticarial lesions with less itch, more pain, and eventually you have fever, malaise, fatigue. You'll have a high CRP, usually more than 3 grams per liter. And in the histology, you'll have a neutrophilic urticaria. Of course, this is a situation associated with a monoclonal IgM-K that you can find in your serum electrophoresis. These are patients that are usually quite well, respond quite well to anakinra. And urticarial dermatitis is a disease that I think is not yet completely defined, but I have quite a few patients with this that have sometimes urticarial lesions, sometimes more eczema. They are usually older patients that have these lesions very pruritic. And when we do histology, we have this spongiosis, but also this perivascular infiltration of T cells and very frequently eosinophils in the perivascular area. This is what we call a dermal hypersensitivity reaction, but I think more we'll have to learn about this. And if you only have angioedema, and it may be bradykinin mediated, and think about hereditary angioedema with low C4 and low C1 inhibitor. These are patients who have angioedema with slow onset and also slow clearing. They have more pain, no urticaria, but they may have this erythema marginatum, as you see in the slide. And of course, they have systemic symptoms, both upper respiratory symptoms that can be life-threatening or abdominal symptoms. But do not forget also this acquired bradykinin-mediated angioedema induced mainly by drugs like ACE inhibitors, but also sacubitril, sartans, gliptins. Be aware of these bradykinins because, as I told you, treatment prognosis is completely different. So for the differential diagnosis, when the urticaria is not typical, apart from clinic, if you have many urticarial lesions, think about CRP, ESR, C3, C4, so complement, serum electrophoresis, and skin biopsy. And if you have mainly angioedema, think also about complement, eventually genetic studies. But how do we evaluate severity? You have some clinical markers that tell us that urticaria is severe. Those that have a longer duration, when we have concomitant angioedema, and when we have concomitant CIndU. These patients are usually resistant to anti-H1, so we have to proceed to further treatments, as you will see. And you know, we have those two main types of CU, type 2 autoimmunity, where you have antibodies against the high affinity receptor. Usually these patients that have antibodies and low IgE, basopenia, and on the other hand, those that have autoallergy and type 1 autoimmunity with high IgE directed to self. These are those that respond fast to omalizumab, whereas the first or slow responders are eventually non-responders. But I think that apart from severity, which is not, for the moment, we don't know at the beginning which will be the most severe and most longer duration, we have to assess activity. And for this, we have laboratory biomarkers and patient-reported outcomes. There are many biomarkers that have been studied, but I think D-dimer and CRP are those that are better connected with disease activity, as you see here. The more severe the disease, the higher are these biomarkers. Interestingly, sometimes you have only high D-dimer, sometimes you have only high CRP, but for the moment, we don't know really what type of urticaria will be more associated with D-dimer or high CRP. And you have the patient-reported outcomes. Urticaria activity score, where the patient will register either on paper, on the computer, the intensity of each and the number of papules and each day. And you will sum up this for 7 days, and you can have a sum that will be above 28, which is a very severe, very active urticaria. And if it is below 6, it is quite a controlled disease. And you can also use the urticaria control test that gives you an idea of the urticaria in the previous 4 weeks with 4 simple questions. And if you have more than 12, it's a well-controlled urticaria, or eventually total controlled if you have 16. Contrary to UAS7, where it is not efficient for inducible urticaria, this one we can use also for chronic inducible urticaria. And in the future, you may have other programs to self-evaluate your chronic urticaria and eventually transmit the results to the patient. So as a take-home message, diagnosis is mostly clinical. Usually it's easy, but you do not forget the urticaria mimicus. And apart from clinic, you have to think about using these laboratory biomarkers. In green, those that when you have urticarial lesions, in yellow, those when you have only angioedema. And for evaluated disease activity or severity, apart from clinical and PROs, you can have laboratory biomarkers like CRP and D-dimers, but also IgE and TPO, because they will somehow predict treatment response, and also the CRP and D-dimer will somehow be a marker of to evaluate treatment response. And with this, I want to thank you for your attention. Thank you.
Thank you very much for this enlightening talk. So we'll move on to the second session, and this is the treatment algorithm and treatment adjustment. What do the recent guidelines say? It's a pre-recorded session by Torsten Zuberbier.
So very nice, good evening to everybody, but maybe this is a worldwide broadcasting. It's still morning, maybe it's already later at night. Anyway, we are going to have great joint scientific fun in these UCARE webinars. In my own position as both Gale and president, as well as member of the steering committee, it's my great pleasure to give you a gist of the ideas behind the treatment algorithm. What do the guidelines say? We're hearing more about these in the webinars, but I'll give you my personal background ideas. Now, just one glimpse where these guidelines were made. It's in the city center of Berlin, where over the years, again and again, we have met and discussed in a group, but not only in ourselves, but jointly with all others all over the world. And just to remind you, urticaria is, of course, the presence of wheals, angioedema, or both, and it's a debilitating disease. We need to do these guidelines. We need to have options. This is a little glimpse into the history, where you see originally, this is the first meeting 2000 was this is 2004. We already had the idea antihistamines, it's the mainstay, and then we have alternative therapies. Nowadays, it's got much more precise. Over the years, you see the different algorithms being involved, evolving further, and now 2020, the last real meeting was there, but unfortunately, not unlike 2016, everybody present, no, a lot due to Corona was online, but still, more than ever, societies participated. And as you can see here, it's a huge paper which has been produced. And I have to highlight again that this, what we say in this algorithm, is very strict, very clearly based on the so-called grade approach, grading the level of evidence, but also allowing the interpretation what is good in real life, ups and downs for patients. For instance, if something is expensive, for instance, if something has high side effects, this needs to be considered. And that's where we come up with strong recommendations for or against, or sometimes, no, we cannot make a recommendation because it's simply not possible based on the absolute evidence level. But what we definitely did do, like in 2016, but now with an online voting tool, to vote and see if we have agreement, and we want to have strong consensus all over the world. Now, going into that, first of all, the classification. It's important to speak the same language with the patient, but also for clinical trials, for real-world evidence, for registries, which is very important in the world of UCARE to collect data. So this is the current typing, and I'm pretty sure you know that, but it's important always to remind ourselves more than one subtype can be present in one person. So you can have chronic spontaneous as well as, for instance, cold urticaria. And this is the big C's. Confirm, look at causes, look at cofactors, comorbidities, and in the end, also look at the course to monitor the activity to understand what treatments we definitely need in the algorithm. The thoughts behind it. Look at the mast cell. The mast cell is the major triggering cell in urticaria. It's a central cell, but it can be elicited by many different stimuli. It could be the IgE receptor, foreign antigens, self-antigens. It could be other receptors the mast cells has, and it could be activated by still unknown factors. So we have to be very open-minded. Another aspect is we definitely know there is sub-threshold disease going on, like in airways disease, this minimal persistent inflammation. We do know that the skin is not stable if you don't see a visible wheal. It could erupt at any second. And what we also do know, histamine is the really important mediator in urticaria. But histamine receptors are upregulated by the histamine itself. So this is the background thought why we need a really consistent, permanent therapy, not just on demand. Hey, there's a wheel coming up. No, we need to be there before the wheel even starts evolving. We've got these instruments like the Urticaria activity score. We have more. I know you're acquainted with them. The Urticaria control test. Retrospectively, the Urticaria activity score, however, gives us a very important information. It can help us to identify certain triggers, like here in this example of a patient. I always have 30 days, a month printed out on one sheet of paper, and then you suddenly see, hey, something happened. Forgot the medication, or stress, or let's say a short course of a disease, which really brings up the inflammatory response of the immune system. It's always like that. If you get even a small common flu, the people get more hives these days because the immune system is really fired on. Now, going on, basic considerations. It's not evidence, it's eminence. No, it's fairness. We should aim at complete symptom control. And there's a strong consensus. We have the possibilities in our treatments, and we should offer them to the patients. And if you look at this modern algorithm we now have, so we start with the old treatments, antihistamines. They are not outdated, but please only use the modern ones. Increase dosage, but don't wait too long. And this is a very important message. If inadequate control, after 2 to 4 weeks, move on if symptoms are intolerable even earlier. And then omalizumab is definitely the best drug we have in our arsenal, and we can play with it. We can increase the dose and shorten the interval. This is new in the new guidelines, and only if this does not work, go on to second generation antihistamine plus cyclosporin, for instance. And if this doesn't work, go to the alternatives, which have low level of evidence. But in the majority of patients, this will work. Second generation antihistamines, first line, increasing dosage, second step, but not, and again, the thought behind that is to play with different pharmacological properties, not mix different second generation antihistamines. Sometimes it's easier for legal reasons, but the efficacy is less good than increasing the dosage of one antihistamine. And definitely not, I jump over that. I know in many areas it's still clear, but you still get referrals from pediatricians using the first generation antihistamine. They are so outdated, not only to these side effects, but mainly due to the fact that they meddle with the brain functions, they meddle with the REM sleeping phase, which is so important also in children when they want to learn. So throw them into the bin. What does updosing really do? In fact, it's more than histamine. And this is a very short glimpse. It shows if you go into microdialysis, updose here in this case in a wheel induced by cold, you see that interleukins, cytokines are affected also by high dose antihistamines. So the message here, antihistamines have anti-inflammatory properties. And this is an important message because this means they can support in addition to blocking the histamine. They should be taken regularly, as I just pointed out. The underlying inflammation is always there, and we want to stop this minimal persistent inflammation. We want to pacify the histamine receptors. But we have to acknowledge maybe they are not good enough. And we all know we need omalizumab as a mainstay drug in this case. However, it is an add-on, and high dose antihistamine add-on, which makes sense due to the fact that inflammatory mediators, apart from histamine, are also controlled. They can work in a synergistic manner. Often, omalizumab is sufficient to control the disease itself, but the idea in the guideline is really to add on, to have as little of an expensive drug as necessary. It's useful, strong level of evidence, so we recommend this. With citrus A, we are less certain. We suggested due to the side effects, but it is the best research alternative if omalizumab is a failure, which luckily is only in a minority of patients the case. And then we have many other options which we really need to know more about. And that's again something where UCARE can help. The registries in UCARE on alternative medication in failures, and they are so valuable. With that, we will get new information. What's clear, the old concept, oral corticosteroids, don't use them. You definitely get a Cushing syndrome, so we recommend against the long-term use. Maybe a short course rescue medication, no problem, but as soon as it's more than 2 weeks, it will give you damage. H2 antihistamines, here's a funny story. In earlier guidelines, there was a recommendation. Then there was a recommendation against because the evidence was so low. Now we are honest, we cannot make a recommendation. I personally think they still are of value in a certain subset of patients who experience stomach problems. Reflux can cause urticaria. The inflammation in the lower esophagus can stimulate mast cell mediator release. And in these patients, maybe H2 antihistamines are useful. I personally always ask about reflux symptoms and then add on H2 antihistamines, but this is not the guideline approach. Children, luckily we are in a position to use the same algorithm in children. Of course, due to the lack of licensing, this is a suggestion, but luckily the evidence is good for all the drugs that they can be used in children as well. And luckily also lactation, pregnancy, we do have a high body of evidence for these situations. Certainly having a woman suffering from strong spontaneous urticaria in pregnancy is not good for the woman, and we need to be able to help her. So finishing in this short, let's say, background thoughts in what is the algorithm, what is our line of thinking behind this. Our biggest unmet need in the treatment is we want to aim at complete symptom control. We've got new drugs, we've got omalizumab, and we have a good chance, but still we need to do further research because we can't promise that. We can promise adequate control, but complete symptom, absence of symptoms, that's our goal. So we keep on doing research, and that again is UCARE. Together we can accomplish that. And maybe as a last thought, this is in the algorithm also, always be flexible in your thoughts, reassess, act, adjust, but not only based on the symptom load, but think with the patient. Maybe something new comes up, maybe we do find a cause, and maybe new drugs are on the horizon which could help further. So always keep in the line of thinking and see your patients again. Don't keep on just giving prescriptions and not seeing them again for a long time. It's always useful to be active. So summarizing, urticarias, wheals, angioedema, or both, it's histamine driven. Anti-inflammatory mediators are important important in other inflammatory mediators are important to block, and that's where high-dose antihistamines are helpful. They are the mainstay of treatment. Omalizumab can be used, and that is new, step up, step down. But the message is treat long enough, high enough. We want symptom control, complete symptom control, and always remember this minimal persistent disease. We have to do something to achieve our goal of Galen for a better life with allergies. Thank you very much for listening and have a good day. Bye-bye.
Excellent talk. Thank you very much. And we were hoping that he would join us live. Please, I'd like to remind the audience to post their questions in the Q&A box, and we'll address the questions at the end of our session. So moving on to the final part of this webinar, treatment options for chronic spontaneous urticaria and chronic inducible urticaria. What's the best for each? A brief overview of the guidelines. So Dr. Désirée, the floor is yours.
Yeah, thank you very much, Iman. And it's really a great honor for me to be here today with you, especially with two very important people in the urticaria world worldwide, Margarida and Torsten. So it's really a great honor for me to be here to share with you a little bit thoughts on treatment, and specifically I was asked to speak about physical urticaria. Now, so what would be here the guideline recommendations? Well, first, the contents of my talk. I'll speak a little bit about the medication that probably is useful in chronic urticaria. You already heard a bit about this from Torsten. The treatment algorithm, and actually it's the same for chronic inducible urticaria as it is for chronic spontaneous urticaria. So I'll go over it again with you. And how to adjust therapy. I'd like to get a little more space on the last slide, the forelast slide. Torsten Zuberbier showed us. I think this is a very nice slide of how we finally came up with the idea that we should be adjusting therapy based on urticaria control test. So how to step up and how to step down. And finally, some words on medication that we have in the table at the end of the guideline, and that's sometimes used as well. For example, the H2 blockers, and there's some other medication there, and some of them might be a little bit more of use in certain types of physical urticaria. So I'll speak a little bit more about that with you at the end of my talk. And then some very last publications, but that's only very recent data. So yeah, the classes of medication we use for urticaria. Now, first of all, still, it's again important to reflect very well on the number one. Urticaria is a systemic disease, so therapy should really be given systemically. There's still come patients into my office using a whole lot of topical corticosteroid creams, and I think sometimes they use so much topical corticosteroid creams that they get a systemic effect and then improve a little bit. But it is a systemic disease, so please, treatment should always be systemically. Torsten already spoke to us about the oral antihistamine or oral H1 blockers. We have the first generation, we have the second generation, and I very much like that Torsten again stressed to us that really we should try to not use any more first generation. Now, there's no place for it. One, yes, because of it has this systemic nervous system effect of sedation. It's been linked to car accidents, even to plane crashes, but it also has the big problem that it's not only directed against the histamine receptor. No, it also goes against other receptors, as Torsten explained to us a bit. But I think one of the very most recent important points in all this is that the crossing with the cholinergic receptor, which makes it partly an anticholinergic drug, this has now very clearly been linked to an augmentation, to a rise in the risk of Alzheimer. And this has been shown very clearly when we also use a lot of old antihistamines for example, allergic rhinitis. So we really reviewed this subject very well in detail, and it's been shown now by several studies that please don't use your first generation antihistamines anymore. Although the patients say they sleep a little bit better, they don't sleep better because sleep quality is also affected. Now, you know, the REM sleep, the REM portion of the sleep, which is so important, this is postponed and shortened when you use old antihistamines. So there are many different reasons now why I also want to stress, please don't use your first generation antihistamines. I'm very happy that Torsten spoke about it as well, although it's not even spoken about in the new guidelines anymore, because generally there was the feeling, no, this is so old, we're not doing this anymore. Well, in my country where I live and work, in Mexico, it's still been done a lot. So I still want to keep on stressing, don't use your first generation, your old antihistamines. And then the biologicals. We have here omalizumab. Then there was a very strong push for ligelizumab. It was trying to be a very good, even better option than omalizumab. Misfortunately, the very latest results did not show any improvement over omalizumab. And if I'm right, the company Novartis decided to abort the development plan of ligelizumab for urticaria, for chronic urticaria. And then there's these other biologicals now, very specifically anti-IL-4, IL-13, dupilumab, now the benralizumab, mepolizumab, anti-IL-5, but there are some trials starting now to use them. Till now, I think there's not been any one of those better than omalizumab for the time being. And then we have the systemic immunosuppressors. Now, Torsten also told us a little bit about cyclosporin A, methotrexate, acetylprine. They're sometimes used, but they really they don't have a clear indication. Now, this is all off-label use. In some countries, even cyclosporin A has not a clear indication for urticaria. In other countries, yes. So I leave that one still open. Yeah, and then I come to this treatment algorithm, which I told you it's practically the same for chronic inducible urticaria as it is for chronic spontaneous urticaria. Now we start off with a normal dose of a second generation new H1 histamine blocker. We can increase up until 4-fold. We also reviewed with the guideline team if we could go higher, if we go to 6 times or even 8 times the dose. Fortunately, the security, the safety part of the new antihistamines would allow us to do so, but really there's no extra gain in going higher and higher up. So we rejected the more than 4-fold rise in treatment in dosing if you want to use a second generation antihistamines. So once the patient does not get better on that, in 2 to 4 weeks, crossing out means if there's no improvement, no control after 2 to 4 weeks, or even before, if the patient is really bad in his urticaria, not sleeping at all, then we go to step 2, and step 2 is omalizumab. Normal dosing, 300 milligrams every 4 weeks, and we add this on, this is an adding on to the high dose antihistamines. If there's no improvement, and here we can maybe wait a little bit longer, but we go up dosing on omalizumab. And the new guidelines tell us that 600 every 4 weeks, we can even go 600 every 2 weeks. This is a little asterisk that's in the bottom of the new guidelines that allows us to go even to the super high dose of omalizumab. But if there's no improvement, here we can wait a little bit longer, 4 to 6 months. If there's no improvement, 4 to 6 months, or no good improvement, then we can think of adding on cyclosporin, or maybe if there's no response at all, really just change omalizumab for cyclosporine. And again, here the SOS, if the patient is in real bad shape, there's really too much affection on quality of life, etc., we can shorten this time before we change gears and go to the next step. Sure, there's also some stepping down. If your patient is well controlled after 3 to 6 months, it might be a good moment to try to step down or to the previous step, or just to try to start spacing. Now, in my clinic, we very much like if the patient is well controlled on omalizumab, we start spacing every 5 weeks, every 6 weeks. When the patient stays well controlled, that might be something you could do or step down. Then you see also the little red bars. When there's acute flares, we can give a short course, but never long-term maintenance therapy, a short course of an oral corticosteroid for less than 10 days. And I like very much also the last part added to this treatment algorithm, and that's when to consider, or when you really must cooperate with a specialist. Now, please don't make patients hanging too long here on the first step. If they're really not improving, consider cooperating or referring to a specialist in urticaria. I think we should not detain patients anymore too long in steps where they're just not getting better. And that's what this very nice treatment figure, which is quite similar to what we see in GINA, in the asthma treatment. And I very much like the idea of GINA, that it's always a circular process. Now, we assess the patient, we have the different diagnostic procedures, we also assess comorbidity, the severity with the urticaria control test. I'll show you a little bit more about that one on the next slide. And also the patient preference. And if there's not a good, stable patient and well-controlled, well, we have to act, we have to change, we have to or step up, or if it's really good, step down in therapy. And that's the way we have to adjust the way we're treating. So when will we decide to move up if the urticaria control test is below 12? Then the patient is really not controlled. And now I'll just show you what is the urticaria control test. You see, this is a very simple 4-question tool, which speaks on how much the patient has suffered the last 4 weeks of physical symptoms of urticaria, of the quality of life, how well the treatment was well or not controlling, and the overall control of the treatment, of the disease, sorry. So once you have here the different points and you add it up 12 or more, then there's quite good control, quite good control. So then we're at 16 when you have the top number of points, but when it's between 12 or 15, you can decide, well, leave this a little bit longer on the same therapy. For example, omalizumab, where it really takes sometimes a little bit longer for the drug to kick in with a full range of effect. Or if it's 12, below 12, then you really should act and move on to the next step. These are then the 2 slides on this table I told you that's also in the guidelines, now in the 2021 guidelines, where we speak about alternative therapies. They have, some of them, hardly any evidence. Others do have some evidence, but it's not strong evidence to put them in the treatment algorithm, as we decided with the group. For example, here, delayed pressure urticaria. Now, there is quite some evidence for methotrexate or mycophenolate mofetil. Also for montelukast, there's quite some evidence for delayed pressure urticaria. Dapsone or sulfasalazine, or more immunosuppressive drugs, also for delayed pressure urticaria. Then for the cholinergic urticaria, there has been 1 or 2 studies with danazol showing some improvement. There was some positive effect there with this anabolic steroid. Sure, it has the negative parts now, especially for the female patients of being an anabolic steroid. And then finally, for symptomatic dermographism, there are some trials showing improvement with phototherapy. narrowband UVB. Then this is the second part of the table. Here again, we have miscellaneous for delayed pressure urticaria again. Anakinra and anti-TNF alpha have shown some improvement in some patients. Then I tried to search some latest data now in the literature on chronic inducible urticaria. It's almost all on chronic spontaneous urticaria. There's really very little literature on chronic inducible urticaria. For example, here it's only mentioned, but the vast majority of it was a case series, but Bilastine, showing that there was improvement. Almost all patients were chronic spontaneous urticaria patients, but there was some of them inducible. And I think this one is an interesting one, the delayed pressure urticaria, clinical diagnosis, features, and responses to omalizumab. Here, Beatriz Beleiro Perez showed us that she was checking the median urticaria control tests, the points that the patient had before omalizumab. See, they had only 3 points. I remember 12 was the cutoff for being well controlled, 12 to 16. So 3 points, that's really miserable. And they went way up to 15.3 almost after already the first dose of omalizumab. So they did really very good. It was a case series of 14 patients, but it was a super fast response in these delayed pressure urticaria patients. This is another one. I think this is a very interesting paper reviewing a little bit more the mechanism behind the chronic inducible urticaria by Dr. Ana Jimenez Arnau. She's one of the super top now experts urticaria worldwide. And she showed us here that the high affinity receptor for IgE, there's an overexpression of this receptor in chronic inducible urticaria patients, just a similar pattern as we also see with the chronic spontaneous urticaria patients. And it was independent of which subtype. It was cold urticaria, heat urticaria, cholinergic, independent of the subtype of inducible urticaria. They all in general saw that the patient had overexpression of the high affinity IgE receptor. And they concluded that this really might lead us to think that there's really an autoimmune activation going on there on the basicles and the mast cells. And that's also why probably anti-IgE could be a very good treatment option. And well, this was shown by the previous study I already showed you. Now, there's another one on cold urticaria, and here they show us that there is quite a great group, a big group of cold urticaria patients that have anaphylaxis. Now, normally urticaria patients don't go on to anaphylaxis. Exactly is the difference now between urticaria and getting wills, but then going on to anaphylaxis. Well, in this case series, they showed that several of them went on to anaphylaxis, and they say it's very important to also give EpiPen to these patients. I doubt, I haven't read the paper in detail, but if these really were then urticaria patients, if they were not just anaphylaxis patients who start off with symptoms in the skin. Then the last one is this systematic review on the treatment options. And finally, they conclude, no, available evidence is very limited. Small samples, small studies, only case reports, not really double-blind placebo-controlled trials. So there's really a need for more information. And then the last paper, I think is only in press. I couldn't find the publication yet, but very interesting, showing us that there's actually seem to be 2 different subtypes of cold urticaria patients. One is a familiar, where they had several patients in the same family, and the other one is just a sporadic one that comes once in a while. Then my 4th last slide is on pregnancy and lactation. I just spoke a little bit about the children, and I'd like to give the last words to pregnancy and lactation. I think also pregnant and lactating women have the right to be controlled in their urticaria, more so pregnancy being a pro-Th2 immune status. But remember that the 4, well, actually the 2, and then 2 of them derived, loratadine and cetirizine are the antihistamines that have such a long history. They are FDA classification B, so they're allowed to be given during pregnancy. And yeah, more probably now desloratadine and levocetirizine, so it's levocetirizine as well. Concluding, treatment of chronic induced urticaria is in principle the same as with CSU, with the chronic spontaneous urticaria. Probably there are several underlying mechanisms, so not all subtypes, and not all patients respond in the same way. So if a patient is not responding well to your therapy, really change to another one. Consolidated treatments and others are still under investigation, as I showed you also, and pregnant and lactating women, they also have the right to be well controlled. So thank you very much for your attention, and we'll still be here for some last questions.
Thank you all for these wonderful talks. And we welcome all the questions in the Q&A box, please. So one of the questions is any suggestions about standard dosing and tapering strategy for steroids, prednisolone, during exacerbations? So do you really need to taper? It's a short course. What is your answer on that, Désirée?
Yeah, if it's a short course, you really don't need to taper. No? You only need to taper if you go over 10 to 14 days. So as you saw here, we recommend 10 days. And personally, I normally max when I do it, it's only 5 to 7 days. It's just to get lower the very high activity patient level of the patient. And then you can just stop them. You don't need to little by little go lower. Sometimes some colleagues like to go step by step downwards to try to avoid the patient from relapsing, but that's not with the idea of the superior suppression. You can just stop it short. I don't know if Margarida wants to add something there.
Yeah, I must admit that sometimes I only use it 1 or 2 days when the patient really has a very, very severe access. So one day, maybe 40 milligrams and 20 milligrams the other day, and that's it. And sometimes they keep on their antihistamines or omalizumab or whatever. Usually with omalizumab, we do not need this steroids, but sometimes on antihistamines, they keep their antihistamines and then take it 1 or 2 days, the steroids.
So this would be a question to Torsten. However, anyone is free to, is welcome to answer. So how effective is the combination of second generation H1 antihistamines, so combining two different?
Yeah, we explicitly state in the guidelines, and we voted on it as well. And we looked for all the evidence that we recommend against combining antihistamines. You just go with one. Yeah.
The question was also combining H1 and H2. Anti-H1 and the anti-H2.
Second generation H1. So
oh, I thought it was
atrazine and loratadine. But actually, this is a very common question as well, and I get, I'm sure everyone gets. Can we? What about combining both H1 and H2?
In my experience, I use it, but very, very seldom, because in my experience, the H2 do not really add much. And at the moment, we don't have any H2 in the market. Cimetidine has gone, ranitidine is gone, famotidine is very expensive because it's not reimbursed. So we don't have anti-H2 to help our patients. But I must admit, I don't think they are of very much help to add to H1.
Now, I sometimes add famotidine. We do have it in Mexico, and it's not such a big problem. The cost it's rare, but I like also that Torsten. I never heard him speaking favorable about H2 blockers, and I think there are some patients. So I sometimes just try it for 2-3 weeks. If I don't see any improvement at all, then we just drop it out.
I know Clive also has quite good experience with adding anti-H2.
Clive, yeah, exactly.
But I must admit, it's not my experience.
I think it's worth trying in countries who don't have omalizumab. So
yes,
it's something.
Or where it's very expensive. It's really a much cheaper option. No?
Yeah.
Sure. There is a question as well about the use of omalizumab in children and the dose. Is it based on IgE?
Yeah, the pediatric dose approved now in Mexico for CSU is 6 years up, and as far as I know, it's just the same doses for the adults. Yeah, in Urticaria, there's no ponderal dose. No, there's no dose based on the weight or the IgE level as in asthma.
Yeah, even though I think we could, in children, we could start with 150, not go to 300 unless they are really heavy. And there are recent data that if you are really heavy, more than 90 or 100 kilos, the omalizumab dose you have to upload. That's not for children, of course, but when we think about the dose of omalizumab, we don't think about weight, and we don't think about IgE levels in chronic spontaneous urticaria. That is really but maybe weight will be important. There was also a question about if we want to target the reduction or the IgE levels in the treatment. I don't think we have to target the IgE levels. We have to treatment control, symptom control.
100%.
Eventually, we know that if IgE goes up a little bit or doubles in the first after the first dose of omalizumab, the chance of responding to omalizumab is higher. But we don't really need to go for IgE levels when using on evaluating treatment response to omalizumab.
Yeah, I'd like to add a little bit on there because I've had some patients. No, I never asked. I normally don't follow up with IgE levels, but some of them, they just check their own IgE levels. And then they were, oh, I need another consulting. I'm really so horrible because my level went up like twice. No, this is normal. No, because when you're measuring IgE, it's total IgE in blood. So the bound IgE to omalizumab circulates longer. So it's normal that the bound IgE goes up after starting omalizumab. So yeah, thank you, Margarida. That was a very good point.
Yeah.
So there's a question about the recommendation on ketotifen, doxepin, montelukast, and CU. What is your recommendation or experience in that?
Yeah, ketotifen is one of the little bit older antihistamines. It gives quite a lot of sedation. I really don't use it anymore. I used it like 20 years back, but that's really with much better things now. And especially if you want to up dose, then with ketotifen, they really get groggy, Then doxepin and montelukast, I already told you where they were in the table. They're in the alternative treatment table of some indication, maybe in some specific cases. But again, yeah, there's quite some adverse effects, especially with doxepin. It's also quite sedating. Montelukast, I used to add it if the patient did not respond to quadruple antihistamines, but it's really very rare the cases that improve. Maybe in CSU when there's a patient who gets flares when he takes aspirin or NSAIDs, then that might be for me an indication that maybe montelukast could help.
What about the role of micronutrients in CSU? So like vitamin D, zinc? Margarida, maybe?
That is a very tricky question. I don't think they are really very important, but we never know. We know zinc, selenium, they have some properties, some effect on the immune system, and they may have some effect. There are some also concerning vitamin D. There are some papers showing that it may be minorly effective, but I don't think they are first line, second line, or third line therapy. They are.
I think only there's really deficiency in Margarida.
Yeah, if there is deficiency, that is different, of course.
So can omalizumab flare up CSU in case of active diseases? So have you experienced a patient who has CSU given first dose omalizumab and then the urticaria flares?
Yeah, I have had such experiences, sometimes not on the first, but on the second or third dose, that the patient is really has a severe urticaria and is not yet controlled. When he takes the drug, he sort of has an aggravation of urticaria before he goes down. I have 1 or 2 cases. Actually, the patient was afraid to take it again, but then we gave it in hospital and with a steroid before, and she improved. Actually, I have more than 2 patients like that. And we have to be aware that if the patient has a severe urticaria, and when we give the omalizumab, when the urticaria is sort of going up, we may have a flare, but that is not so often. And it is not anaphylaxis. Sometimes it is described as anaphylaxis. It's not anaphylaxis. It's urticaria that is going up, and it takes some time for omalizumab to. And in my experience, these are the patients who have very low IgE, that have probably type 2B autoimmunity, where omalizumab takes some time to respond. So in these cases, you have the antibodies to IgE receptor, and it takes quite a long time for the IgE receptor to go down after you treat these patients with omalizumab. So in the first months, they will not respond, and they may have these flares, but then they may respond. Most of them will respond, or otherwise they will respond to cyclosporine.
This answers the question. There was a question about if IgE level is low in CSU, should we still use omalizumab? And you've touched that question.
Although with a little bit more patience. And that's why in the algorithm it says, if there's no improvement after 6 months, we can go a little bit longer in those patients before there's a good response.
So what can we use for? Yes, sorry, Margarida.
I must say that in these patients that have very, very low IgE, I have tried cyclosporine because at a certain time I had difficulty in assessing omalizumab. And these patients with very low IgE respond quite well to very short courses of cyclosporine. And we can tap a cyclosporine after 3 or 4 months, and they can stay 2 or 3 years or many months without urticaria. And when it relapses, we give them cyclosporine again, and they will resolve. Of course, some patients have side effects and we cannot, or have contraindications and we cannot use it. But we recently published it at GADV that we can have short courses of cyclosporine in these patients with very, very low IgE, and we can have good control of urticaria for rather long periods.
So can you use 4 times the antihistamine in pregnancy and lactation, maybe for Désirée?
Yeah, I should try not to go there, but if you have to go there, I think there's not a major problem, and not for long times, but I still favor this over going to immunosuppressants or the corticosteroids. No? So yeah, I do it sometimes, rarely, because we always try to also have control of all other symptoms and all other factors around it, aggravating factors specifically. But if it's needed, then it's for 2-3 weeks, and normally then they calm down again. Yeah.
So what would be the maximum dose in your case?
Quadruple, but with I normally go with levocetrizine. Yeah, 2.
So which dosage of prednisolone you advise in very severe and resistant acute urticaria?
I normally do 1 milligram kilo with max of 60. 6-1 daily. Prednisone.
Yeah. I do similar dose, but I think in acute urticaria we have to tell our colleagues that we cannot do a single shot or a single day of prednisolone, because otherwise you'll have a relapse. Mm-hmm. If you are treating a patient with acute urticaria, if it's very severe, I think you can give a steroid, but then you give it for a few days afterwards, and always with antihistamine.
That's important. Yeah.
Never do a single shot. Sometimes in the emergency, you give a IV prednisolone, the patient feels better, go home, and then a few hours he's back. So never do it like that.
Yeah.
So probably the last question, if antihistamines, omalizumab and cyclosporine fail, what will your options be?
I reconsider diagnosis. I go back to step one. I go back to step one completely.
Yeah, I agree. I think we have to rethink it. And if you go back and it's really urticaria, I have tried dupilumab in a few patients, it goes okay. Not really very, very okay, but it improved. I've tried mycophenolate, methotrexate, but
Combining, I would say combining cyclosporine and omalizumab.
Yeah, I've done it also.
Do you think there's a difference between combining omalizumab and cyclosporine alone in your practice?
Yes, in these very severe patients, I think you get a gain of combining.
Yeah.
I think one last question in the Q&A I can see, is it important taking into consideration the level of anti-TPO while IgE is very low, so type 2B? Would that change your management, or you'd still go ahead with the guidelines as it says?
I would still go ahead, only I would be more keen that if there's really no improvement after 4 months omalizumab, probably change to immunosuppressants.
Yeah, that's true.
Right, thank you very much. I think we're probably a little bit over time. So we would like to thank all our experts. Thank you very much for this very enlightening talk. This is very, very useful indeed. We thank all the attendees, everyone watching. It will be posted on YouTube, and we'll try to translate, all these lectures will be actually translated in different languages. So please stay tuned. Thank you all very much.
Thank you. It was a pleasure to attend. Thank you, Iman. Thank you, Désirée, and thank you, Torsten, also for your input.
Take care. Thanks a lot.
Take care.